It is hosted under the Nuvega Clinical Conversation Series. Thank you for taking the time to join us today. And despite of your busy schedules, reflecting your continued commitment and advancing patient care and staying at the forefront of oncology practice. Today, our first speaker will be Dr. Paulavi Vasu from NSCRI Hospital. Will share the valuable insights into the reaching the new heights in NHSPC care. Now, it's up to you, ma'am. Madam, shall I share the slides?
Kindly share the slide.
Yes, sure. Hmm. Madam, it is visible?
Yeah, visible.
Okay.
Okay. So first of all, thank you, Bayer's team, for giving me this opportunity. So today's talk is regarding prostate cancer management. So mostly we are talking about metastatic hormone-sensitive prostate cancer. So whenever a prostate cancer patient comes to our OPD, first of all, we have to know the stage. So we do PSMA PET-CT scan for all patients, whether it is localized or metastatic. So if it is localized, we have options of radiotherapy. We have options of ATD. But if it is metastatic, then we have so many options. So according to patient performance status, disease condition, patient stage, we have triplet drug option, we have doublet drug option. So now coming to treatment landscape. So if it is localized disease, as I have already mentioned, that we have options of radiotherapy or ADT treatment. And if it is recurrence, if it is biochemical recurrence, we continue with ADT. If there is consecutive 3 rise of PSA value and still it is non-metastatic, we termed it as non-metastatic CRPC. And in non-metastatic CRPC also, we have lots of options like darolutamide, apalutamide. So, and if it is metastatic, means when there is consecutive 3 rise of PSA value and PSMA PET-CT when revealed that there was a obvious mix, we term it as metastatic CRPC. So today's topic of discussion is regarding mainly metastatic hormone-sensitive prostate cancer. So next slide. So if it is newly diagnosed metastatic hormone-sensitive prostate cancer, we have triplet drug therapy or doublet drug therapy. So initially we have this TEMPEST trial data where they use doublet regime where they use docetaxel only, and there was a clear-cut benefit of overall survival. Next slide. So now coming to that era when we determine whether it is oligomates or not. So whether it is less than 4 bone mates or more than 4 bone mates. Next slide. So we have to use some sort of drug so that we can delay the progression, we can delay the metastasis. Next slide. So now coming to charted data where they use docetaxel in metastatic hormone-sensitive prostate cancer. They compare, they include both high volume as well as low volume prostate cancer disease. And they were randomized into 2 arms, docetaxel plus ADT versus only ADT. And there was clear-cut median overall survival benefit, 34 months versus 51.2 months with a hazard ratio of 0.63. So there was improvement in overall survival, 16.8 months. And for low volume disease also, there was improvement in overall survival. But yes, if it is low volume disease, we can the hazard ratio is not very much convincing. Hazard ratio was 1.04. Next slide. So now coming to latitude data, where they use abiraterone in high risk group of metastatic hormone sensitive prostate cancer. And again, there was benefit. So abiraterone was the first to show that hormonal treatment can be effective. So these are the treatment options for metastatic hormone sensitive prostate cancer. Next slide. Now coming to the side effect profile of abiraterone, because we know for abiraterone we have to use steroid, prednisolone 5 mg BD dose, twice daily dose. So if patients have mostly prostate cancer patients mostly affect more than 70 years of age. So elderly population, mostly patients have lots of comorbidity like diabetic, hypertension, cardiac pre-existing cardiac disorder. So abiraterone itself sometimes causes hepatotoxicity, sometimes patient causes hypokalemia, and if patient is diabetic, we are using steroid along with abiraterone, so it may hamper their glycemic control. So these are the pitfall of abiraterone, we can say. Next slide. Now coming to Titan data, where they use apalutamide in metastatic hormone-sensitive prostate cancer and see the result. Irrespective of volume of disease, there are subgroup analysis where they showed that in even in low volume disease, there was progression-free survival benefit with a hazard ratio of 0.36. And in high volume disease, again, there was PFS benefit, overall survival benefit with a hazard ratio of 0.53. Next slide. Now coming to Enzalutamide data, enzalutamide, where they use enzalutamide in metastatic hormone-sensitive prostate cancer and see the overall survival benefit. Again, there was overall survival benefit with a p-value of 0.43 in low volume disease, and for high volume disease, a p-value was 0.80. Next slide. Now coming to triplet drug therapy. Next slide. Triplet drug means we have two data. One is peace trial data where they compare abiraterone, yes, around they include all de novo metastatic hormone sensitive prostate cancer patient. Around 1173 patients were there, and they were randomized into two arms. One arm received abiraterone plus docetaxel plus ABT, and another arm received abiraterone plus docetaxel plus ABT. Next slide. Now see the result. When they combine this triplet combination, irrespective of volume of disease, there was benefit. Even in mostly in high volume disease, there was more benefit, but in low volume disease, it did not seem to be beneficial as a high volume disease. So if it is high volume disease, we should use this triplet drug combination. But if it is low volume, we can use this triplet combination. But yes, the survival data is not very much convincing. Now coming to our darolutamide study. Next slide. Now coming to this ARASENS study, where they combine this triplet combination, where they include docetaxel, ADT, along with darolutamide, 600 mg BD dose, and the second arm received placebo along with docetaxel plus abiraterone. Primary endpoint was to see the overall survival, and the secondary endpoint was to see the disease to time to progression, time to CRPC, time to pain progression, and as well as to see the safety profile. Next slide. Most important that if we compare PEACE-1 versus ARASEN, we can say treatment discontinuation rate is very less. Now these are the results. There was overall survival benefit with a hazard ratio of 0.68. So 30% reduction in the risk of death, both in high volume and low volume disease, there was benefit. Next slide. Now coming to secondary endpoint like time to CRPC. So as I have already mentioned that whenever we are using this triplet combination, it delays the disease progression. So you can see the clear-cut separation of these two Kaplan-Meier curve where they include triplet drug combination versus doublet. Time to subsequent antineoplastic therapy, again there was clear-cut separation of these two Kaplan-Meier curves, 61% reduction with a hazard ratio of 0.39. Next slide. Now see the PSA response, which is most important. So mostly we can say that mostly patient, there was a clear-cut overall survival benefit, undetectable PSA at 36 weeks and with a hazard ratio of 0.37. So more than two-thirds of patients reached below the value of 0.2 in the overall study population. So the PSA response is excellent, even in high volume disease where sometimes patient presents with a PSA value of more than 200, more than 250. So after giving this triplet combination, we can achieve this excellent PSA response. Next slide. Now coming to in low volume disease also. So there are some subgroup analysis which showed that darolutamide, this triplet drug combination achieved achieved better PSA response and outcome even in low volume disease also. Next slide. So time to PSA progression or time to CRPC is delayed. So there was clear-cut benefit between this darolutamide plus docetaxel plus ADT versus ADT plus docetaxel. Next slide. So now we have two options. One is doublet versus triplet regime. So first of all, we have to see whether it is high volume disease or low volume disease. Second is patient factor is important. Patient age, patient comorbidity, whether patient is diabetic or not. So these are the factors which we usually see before starting any sort of therapy. Next slide. So we can say that for metastatic hormone sensitive prostate cancer, we have so many options. We have triplet drug combination. We have abiraterone docetaxel plus ADT. We have options of darolutamide docetaxel plus ADT. But yes, if we compare the safety profile, the this ARASEN study is very much convincing. More less number of patient discontinuation rate is very less, and the disease progression, if we see the disease progression rate is less. So there was no clear cut difference. There was no head to head trial where they compare these two drugs, but we can say that in darolutamide, the response rate as well as the safety, which is very important, mostly patient, the discontinuation rate is very less. So that's why we can use this triplet drug combination so that we can delay the disease progression or we can achieve good PSA response. So with this, I think I would conclude my talk. Thank you.
Thank you, madam, for your wonderful presentation. Dr. Tanmay Mandal will be joining in a while. He just called me. He's somehow busy with some patients. So just hold on for some time. That is joining in a while. Sir, good evening. Converse, sir. Sir, good evening. Sir, I think there is some technical glitch. Can you please log in 1 second? I think some network issue is there. So, so you just once log out and log in once again. Yes, sir has already joined. Sir is having some network issue. Sir has requested me to share the slides. I am sharing the slides for Dr. Kanwar. Sir, is it visible? Hello. Sir, sir, you are not audible.
Yes, sir.
Yeah, hello. Actually, Dr. Tanmay Mandal is facing some technical problem. So somehow we are not audible to him. He called me twice and thrice, but somehow he is having a technical glitch. So just we are waiting for 1 or 2 minutes. If this continues, then we will call off this meeting.
Okay, sir.
Okay. Just wait for 1 or 2 minutes.
Okay, sir. No problem.
Okay. Hi, tech team.
Yes, sir.
Sir has called me. He's just going to another room where there is some another Wi-Fi connection. So once again, sir will join in a while.
Okay, sir. No problem.
Yes. Okay.
Hello, sir.
Yeah, hello. हेलो।
Yes, sir. डॉक्टर कब तक ज्वाइन करने वाले हैं सर?
डॉक्टर से तो कुछ देर पहले भी बात हुआ था, अभी 10-15 मिनट पहले। वो तो बोल रहे हैं कि ट्राई कर रहे हैं, लेकिन हो नहीं रहा है। तो क्या करें, क्लोज कर दे क्या? कितना देर वेट
जैसा सर।
करेंगे? कोई डेफिनेट टाइम तो मुझको वो बता नहीं पा रहे हैं। आप एक काम कर सकते हैं, आप थोड़ा लॉगिन करके रहिए। अगर अभी तो नहीं तो अगर वो ज्वाइन कर जाते तो मैं कंटिन्यू कर लेता हूँ फिर। नहीं तो फिर क्या करूँ, आप बताइए।
अ, आप बोलिए सर, डॉक्टर से क्या बात हुई? डॉक्टर के यहाँ टेक्निकल इश्यू है तो।
डॉक्टर के वहां पे नहीं, वो एक्चुअली वो एक जगह पे कीमोथेरेपी रन करवा रहा है एक पेशेंट को। तो वहां पे नेटवर्क का इशू है, वहां पे नेटवर्क नहीं मिल रहा है उनको। दिक्कत वहीं पे है। और वो वहां से निकल नहीं पा रहे कि वो दूसरा रूम पे शिफ्ट हो जाए।
ओके सर।
तो यही दिक्कत आ रहा है। मैंने 2-3 बार उनसे ओवर द फोन बात किया, लेकिन वो वहां से निकल नहीं पा रहे हैं। उन्होंने तो लॉग इन किया था 1-2 बार, लेकिन वो प्रॉब्लम तो परसिस्ट कर जा रहा है बार बार।
ओके सर।
So can we have the slide deck if feasible?
यस सर, यस सर, यस सर। गुड इवनिंग सर। सर
Good evening.
थैंक यू फॉर ज्वाइनिंग सर। आई एम जस्ट शेयरिंग द स्लाइड्स। सर, दिस इज अ स्लाइड डेक फॉर टुडेस मीटिंग।
It is not visible as of now.
Okay, sir, just a minute, just a minute,
Hmm.
just a minute. I'm sharing once again.
No. Yes. No, just almost 2 minutes.
Sir, is it visible?
Yes, yes.
Thank you, sir.
So advancing metastatic HSPC treatment horizons, darolutamide without chemotherapy, the ARANOTE evidence. Next slide. Next slide. Okay, so this is the standard of care for metastatic HSPC setting, as we all know. So I have seen we know about the ARASEN study, the other studies also, but today's discussion is mostly on the ARANOTE study. What we know mostly, my take on the ARANOTE study is that for elderly patients who have multiple comorbidities with difficulty in many issues, it's better to go ahead with a single agent darolutamide in the metastatic HSPC setting, and it has been seen that it has proven beneficial in this subset of patients in the ARANOTE study. With this next slide. So darolutamide plus EDT with docetaxel is the standard of care that we all know in the ARASEN study. ARANOTE was designed to evaluate darolutamide plus EDT versus EDT to provide the new treatment opinion for patients without having treated with docetaxel. Next slide. So this is the study design as we all know. Next slide. So patient characteristics, it had a good Asian population subset. Metastasis at initial also was around 71%. So good country-wise representation was seen. Next slide. This is all we know. I think we can go to the PFS and the OS all benefits Kaplan-Meier slides. Next slide. So this is the primary endpoint radiographic PFS which we had. There was a benefit in the radiographic PFS in the as evidenced in the Kaplan-Meier slides. This is the forest plot which favors that high volume, low volume both benefited with the use of single agent darolutamide also. Next slide. delayed the time to CRPC also and the time to pain progression also. This is the delayed to time to pain progression and the delayed deep and durable PSA response was also seen with the use of darolutamide alone with ADT. Next slide. Next slide. So higher proportion of patients achieved an undetectable PSA with darolutamide versus the placebo. This is the patients with subsequent life prolonging systemic antineoplastic therapy. Also around 32% in the darolutamide arm. Next slide. This is a well tolerated drug, as we all know. The usage is good, and discontinuation is also less. Next slide. This is, I think, regarding the side effects, which we'll be having next slides 2 to 3. Next slide. Common side effects. Fatigue is the most common side effect associated with ARPI is very similar across all Cs. They impacted positive quality of life also. Next slide. Next slide. Okay, so doublet therapy demonstrates a meaningful delays in the deterioration of the overall well-being. In conclusion, also, darolutamide plus ADT significantly improved the radiographic PFS in patients with metastatic HSPC. It showed a benefit across all secondary endpoints associated with the deep PSA response regardless at the baseline PSA, and it helps in the first and only AR inhibitor to demonstrate a meaningful delays in pain progression, overall well-being, and had a favorable safety profile. With this, I think we end this talk for today.
Thank you, sir. Thank you for your presentation and giving time. Yeah, dear all doctors, by this we'll end our session for today, and I am confident that the expertise of the HCPs and their perspective will make this session both engaging and enriching for all of us. And we hope in future we would give you some more platform where we can discuss about the new outcomes of darolutamide. Thank you once again for being here, and I wish you all a very highly informative and productive discussion. Good night.